facial appearances of our patients, not only facial but also skin appearances of our patients with rhasopathies, especially with Noonan syndrome. And these are the genes who are involved in the individual patients. There are multiple additional genetic conditions, mostly named syndromes, with defective DNA expression, transcription, replication, and repair on the level of the regulation of the chondrocyte. They can be detected on the genetic level, some of them also clinically. But the question is, does it exactly matter in a resource-limited setting to have this diagnosis? In fact, I do not think so. And it's up to you to decide clinically, or maybe to try to find a collaborator who can help you with genetic diagnosis. So the landscape of short stature is complicated. By sure, there is a group of growth hormone deficient. There is a slightly overlapping group with born small for gestational age with short stature persisting in childhood. There is also a group of familiar short stature overlapping with the others. Turner syndrome, SHOX deficiency, rhasopathies, neurofibromatosis that's slightly related to the rhasopathies, Prader-Willi syndrome, chronic conditions that we already mentioned, Silver-Russell syndrome and other syndromes, growth plate disorders in general. And what's the rest? This is the landscape of the so-called idiopathic short stature. So we still do not know what's behind. But we have just one medication, and that's growth hormone. And most families come with the question, should our child get growth hormone? And now it's up to you to decide, yes or no. Yeah, it is important to consider what's the reimbursement. Because growth hormone is an expensive medication. And it can be helpful only on the long term. So it makes no sense to enforce the family to invest all what they have into a short course of treatment with growth hormone. In that cases, better not to start. But to work with the health authorities that growth hormone should be available and reimbursed or paid by the government for those who are most severely affected. And these are especially children with growth hormone deficiency and especially with the severe growth hormone deficiency. Those with the SGA-SS are in Europe the next candidates for getting growth hormone. Girls with Turner syndrome also, but the effectiveness is inferior to the effectiveness in growth hormone deficiency. SHOX deficiency in general is also an indication here in Europe. The chronic kidney disease, Prader-Willi syndrome, also the rhasopathies. Why not the others? No, because simply it was not tested. So it could not be confirmed that it is safe, probably it is, because growth hormone is in general safe, but that it is efficient. So this is the landscape that's now approved at this stage in Europe for treatment of with growth hormone. In the US, maybe you may know that the idiopathic short stature is also included, but I am not sure if all are, if it is reimbursed for everybody. Well, so now it is an open question, and the continuing of this question and getting the answers is more or less in your hands. So I tried to open the insight into the growth disorders, and I'm bringing you the best regards from my home city, Prague, Czech Republic, Europe, and I'm very grateful to our team in our Motol University Hospital for the decades of wonderful collaboration, stimulation, and helping together the patients and the medical knowledge and education. Thank you for your attention.
Again, we very much appreciate the time and effort that Dr. Level spent in providing us with that excellent talk. Again, if anybody has questions from Dr. Level, he would welcome them by his email. At this point, we're going to move to a 5-minute break, and after that is going to be our Meet the Expert session. So you can take a few minutes and then work toward migrating in that direction. And it was good to see everyone and meet everyone, even if it was only online. I hope to meet some of you in person someday. Good day.
Greetings from GPED. The growth and productivity symposium has now concluded. And to the next session. Thank you.
To this meet the expert session. It's an honor for me to introduce you to Hasmani Lajous. She performed her training in France, and she's currently involved in a lot of sorry, the audio is it's making an echo. So she's involved in several organizations such as the Global Pediatric Endocrinology and Diabetes Society and the ESPE. So, Dr. Asmani, I'm gonna give you the cue so you start.
Thank you very much. Um, Thank you very much for the nice introduction. Do you see my presentation? Okay, I will say that it's here. So
This
hello,
meeting is
everyone.
being recorded.
I'm very happy to be with you for this presentation. So to make it more interactive, you can participate by scanning this QR code, and there will be some question, and you can answer the question via WooClap. Don't worry if you don't have the code yet. It will be reminded in each question. So first, this is a small survey. Can you tell me if you have to manage some patient with non-vitamin D deficient rickets? Do you see them once or twice a year, every month, more than once a year, or we will say in the end of the presentation? You can still continue to answer the question. So I think you are all pediatrician or endocrinologist, and you know that normal bone growth and mineralization require adequate calcium and phosphate. That are the two major nutritional elements that constitute mineralization can resist. And rickets is actually a disease of the growing bone, and we will see it only in children and adolescents, while osteomalacia have the time. Two patients with rickets, the first one being a 24-month-old female patient who was referred for short stature. As you can see, she was from a non-consanguineous healthy parents. She has a 5-year-old sister in good health. She was born full term, and she had actually a normal developmental milestones with, and she was capable of standing at 15 months and walking at 18 months. Her vaccination were up to date, and she received vitamin D according to our national program of ricket prevention, which consists on giving 2 doses, high doses of vitamin D at 1 and 6 months. You can see that at first examination, she was really short with the height at minus 3.3 standard deviation with a normal BMI. And you can see that she had plus this short stature, frontal bossing, also a hypertelorism, distension, rachitic rotary that we will see in the X-ray. The hair were normal. She had a slight genuvara and widening of the growth plates, the knees, the wrists, and the ankles. The X-rays of the hand and of the lower extremity showed metaphyseal cupping and fraying, blurred metaphyseal lines. I don't know if you see the arrow, poor mineralization of the epiphyseal centers, and irregular and widened epiphyseal plates, and also an increased distance between the end of shaft and epiphyseal center. The thoracic X-ray showed rachitic rosary and the beading of the ribs with a parenchymal haziness. So this 24-month-old girl presented with clinical and radiological signs of rickets. So the first question you can start to answer is what would be your first line investigation? What would be the first lab exam that you can do? Calcium, phosphorus, alkaline phosphatase, blood gas, TRP. Oops, no one has answered. Okay, I will let you, yes. For the first line, yes, I will go on. And exact, you're right. So this is what I would do in a first line investigation. This can be different considering the country or the place where you work, but some of the other exams are not available in our country. So we will do the alkaline phosphatase to confirm the rickets. And what is very important is that you consider it. You consider the normal values according to age. Of course, calcium is mandatory to explore calcipenic rickets, phosphorus to investigate phosphopenic rickets, magnesium because in some cases magnesium can be low, leading to a low calcium. PTH and vitamin D will permit to exclude vitamin D deficiency, and also in some it may be interesting to have a urinary calcium and phosphorus. So here is what we have done with what we have asked for our patient, and I will let you read this slide. You can see that calcium was normal, phosphorus was low, ALP were very high, 25 hydroxyvitamin D was in the normal range, as well as PTH, and there was no calciuria, and also she had a normal renal function. So at this stage, what will be your most likely what will be the most likely diagnosis at this stage? Do you think that she had vitamin D deficient ricket, and we have to treat her before excluding this diagnosis? Vitamin D type 1 rickets, vitamin D dependent type 2 ricket, hypophosphatemic rickets, or cystinosis? I will let you some minute to answer. Okay, so it's true that it's the title of the presentation. It's hypophosphatemic rickets. Why? So it's probably not a hypocalcemic rickets and not a vitamin D deficient ricket. She received the vitamin D, and also she had normal level of vitamin D. Calcium was normal, and it was not very consistent with hereditary vitamin D dependent rickets. Calcium was normal, and normal vitamin D levels was normal, and phosphorus was low. So it's probably in the global field of hypophosphatemic rickets. So here is a table with the main characteristic of the different types of rickets. And it's true that in vitamin D deficiency, usually vitamin D is low. Calcium, may be low or normal in some stages, as well as phosphorus. Alkaline phosphatases are always high, and PTH also is high because vitamin D is low. In this case, we don't have to actually do FGF23 or TRP. In vitamin D dependent rickets, usually calcium is low. So it was not the case in our patient, and also PTH is very high in all the cases. With vitamin D, it depends of the type of vitamin D, maybe low or normal or high. And of course, in hypophosphatemic rickets, usually calcium is normal, phosphorus is low, alkaline phosphatase is high, but not as high as in the calcipenic rickets, and usually PTH is normal or is normal or slightly high, and FGF23 in some cases is high, especially in XLH. So this patient probably had hypophosphatemic rickets, and this is the second line investigation that we did in our patient. So glucose, we checked for glucose in the urines. We checked for phosphates in the urines, and we calculated the phosphate reabsorption rate. And at this moment, FGF23 was not available. But even without FGF23, we can have an idea of the diagnosis. So what do you think that is the diagnosis? We will see it later. You know that FGF23 and PTH reduce the renal tubular phosphate reabsorption by reducing the apical expression of the sodium phosphate cotransporters, and PTH will stimulate, while FGF23 will inhibit 1,25-dihydroxy vitamin D production. 1,25-dihydroxy vitamin D increases the intestinal absorption of the dietary phosphate by enhancing the transporter and stimulating the FGF23 synthesis. So PTH and FGF23 will affect each other's production through a negative feedback loop by as yet unknown mechanism. And you can see in the boxes the sites of the defects of the different causes of hypophosphatemic rickets. So the most frequent one is XLH, but there are also other causes of genetic hypophosphatemic rickets, autosomic recessive hypophosphatemic rickets, autosomic dominant hypophosphatemic rickets, and also, of course, there are the tubular hypophosphatemic ricket due to some renal disease. So in our patient, what is the most likely diagnosis? Do you think it's a Tony Dobré-Fanconi syndrome due to cystinosis? Do you think it's an autosomic dominant hypophosphatemic rickets due to McCune-Alward syndrome, X-linked hypophosphatemic rickets, or a Dent disease type 1? I will let you some minutes to answer. Okay, so yes, X-linked hypophosphatemic rickets is the most frequent one. Oops. And there are different diagnostic approach to the diagnosis of hypophosphatemic rickets. And this one, I use this one because you have seen that FGF23 was not available in our patient, and it's not done routinely in Algeria. We have to send the blood in another country. So what I do is that in front of hypophosphatemic rickets, first I will check for glucosuria to exclude Tony Dobré-Fanconi syndrome, because because we have a high level of consanguinity, we have some diseases that are more frequent than in other countries. And then if the glucosuria is normal, I will check for the TRP, so the phosphate reabsorption rate. If there is a high TRP, it means that there is a renal conservation of phosphates, so it's probably a nutritional phosphate deprivation. And if there is a low TRP, it means that there is a phosphate wasting. And then I will do a dosage of 1,25-dihydroxy vitamin D, and also a urinary calcium. And if there is calciuria, it's a non-FGF23 mediated hypophosphatemia, while where there is calciuria, or if it's if it's low or normal, if it's probably a FGF23 mediated hypophosphatemia, so, and the most frequent one being XLH. So there are other diagnosis approach where the main the first investigation is PTH, and also when you can use the FGF23, with FGF23 being normal or low will be the HHRH, so hereditary hypophosphatemic rickets with hypercalciuria and Fanconi syndrome. And if it's high, it's the XLH and other acquired forms of hypophosphatemic rickets with FGF23. But for us, it's easier to measure glycosuria than FGF23. So let's go back to our patient, and so she didn't have any glucosuria, so it was probably not a Tony de Fanconi syndrome, and the phosphate reabsorption rate was low. So this means that she had decreased tubular phosphate reabsorption without hypercalciuria, and it means that we were correct, and it is a FGF23 mediated hypophosphatemia, and FGF23 levels, when they are high, it means that it's a hereditary form of FGF23 dependent renal phosphate wasting, but also macular bright syndrome, some drugs, etc. And so here is the list of the genetic causes of rickets or osteomalacia with elevated FGF23. I'm sorry, but the slides, they go on just by themselves, so I don't know why it's too fast. But so the X-linked hypophosphatemia is the first diagnosis that we should consider in presence of clinical and or radiological signs of rickets, if there is an impaired growth velocity and serum level of phosphate below the age range reference, with a renal phosphate wasting, and in the absence of vitamin D or calcium deficiency. So those are the clinical practice recommendation. So in our patient, because she had probably a FGF23 mediated hypophosphatemia, we have to consider the diagnosis. You know that XLH is the most frequent cause of phosphate wasting. It's an X-linked dominant inheritance with the complete penetrance, and the physiopathology is due to a loss of function mutation of the FEX gene that will lead to excess level of the FGF23 and will lead to renal phosphate wasting and a decreased 1,25-dihydroxy vitamin D production. So this will lead to low phosphate in the blood and high phosphate in the urine. The key clinical characteristics are rickets, disproportionate short stature, and osteomalacia. And the children will have the clinical symptom within the first 2 years of life, but often diagnosis is delayed due to the diversity of the clinical manifestation and the rarity of the disease. So here are the signs that can be seen in childhood and in adulthood, and you can see that in childhood we will have this delayed and disproportional growth, craniostenosis, rickets, of course, and sometimes delayed motor development and gait abnormality. And sometimes something that is common with the adult is the short stature, the deformity of the limbs, the tooth abscesses, and the excessive dental caries that we have to check, and also bone and joint points, muscle pain and weakness, and some other presentation. So how do I manage a patient with XLH in Algeria? First, of course, we have to do an initial diagnostic workup for the evaluation of the common complication. We've seen the growth in our patient, the signs of rickets. We can measure the intermalleolary distance and the intercondylian distance, also the head circumference and the skull shape, the neurological examination, the hearing assessment in older children, as well as the dental and oral examination. The initial workup should also contain some biochemistry, so in the blood calcium phosphate and creatinine, in the urine calcium phosphate and creatinine, so we can measure the calcium on creatinine ratio in the urines. The TRP or the TMP GFR are interesting to estimate the phosphate wasting. Also, we can have the blood levels of 25-hydroxy vitamin D or 1,25-dihydroxy vitamin D, PTH, of course, ALP in children, and intact FGF23 if it's available. Imaging workup, like we have done in our patient with the wrist and the knee usually, or the hand and the lower limb, and sometimes standardized well-positioned anterior posterior standing limb alignment radiograph. In older children, we can do a dental orthopantomogram and also brain MRI in case of craniostenosis. So once we have do all the workup, what would you recommend in the first treatment in this patient that we have seen? So what is the recommended initial treatment for patient with XLH, the conventional treatment? So one is calcium supplements, phosphate supplements, and vitamin D3. 2 is phosphate supplements only. 3 is phosphate supplements and vitamin D3. 4 is phosphate supplements and alpha calcidiol. And 5 is burosumab. Okay, so yes. So the correct answer is phosphate supplements and alpha calcidiol. She didn't have any hypocalcemia, so they don't need calcium. So phosphate supplements and active vitamin D analogs are the main elements of the conventional treatment. So what we do is we give phosphate supplements. We can start with 20 to 60 milligram per kilo per day. And what is important in small children is to give it 4 or 6 times daily with a progressive increase up to it's better not to go up to 80 milligram per kilo per day. And in younger children, usually we give 60 milligram per kilo per day. Of course, alpha calcidiol is given. So the usual dose is 30 to 50 microgram per kilo per day. And we can start with 0.5 or 1 microgram per day. And if there are low level of vitamin D3, we will give vitamin D3 supplementation. So here are the recommended the doses of phosphate supplements and vitamin D throughout life, and you can see that in infancy the phosphate supplement dose is higher than in childhood and puberty. And for the vitamin D analogs, it's the same. Usually we give 1 to 2 microgram per day, and we will, of course, monitor the efficacy and the safety. So the goals of the treatment is, of course, to relieve the pain, to normalize the alkaline phosphatase level, to increase the growth velocity, and to straighten the legs. But you can see that it's not done, it's not very quick. And so what is quick is the decrease in bone pain. This is obtained in a few weeks, but even the normalization of alkaline phosphatase level is only done in 6 to 12 months. For the growth velocity, usually it takes 1 year, and the straightening of the legs, it can take more than 3 or 4 years. Also, what is very important to prevent nephrocalcinosis is to maintain the calciuria levels within the normal range and to avoid large doses of phosphate supplements. So we have to adopt measures to decrease the urinary calcium concentration, excretion, etc. And if there is a secondary hyperparathyroidism, we have to increase the active vitamin D or decrease the oral phosphate supplement. And in some cases, calcimimetics may be considered, or even parathyroidectomy. So in our patient, after the first visit, we could confirm that FGF23 was high, and also we had the genetic analysis, and the FX mutation was confirmed. So we started with phosphonerose 4 times daily, and then 3 times daily, and we gave her 1 microgram per day of 1 alpha vitamin D, alpha calcidiol. And of course, we have to monitor this. So usually in the young children, we see them monthly, and then every 3 months. And we will monitor height, weight, and also EMD and IMD and ICD. We will check for the dental examination in the older children, and in older children, it will be every 3 or 6 months. Serum level of ALP are very important, as well as, of course, phosphate, but we don't want to normalize the phosphorus level, but ALP must be normal usually. And we will check for the calcium creatinine ratio to make sure that there is no risk of nephrocalcinosis. And what we also do is we do a renal ultrasonography every 1 or 2 years, and we will check for the X-ray every 1 year usually. So here's the outcome of our patient. So you can see that we increased the phosphate supplements progressively, as well as the alpha calcidiol. So you have to know that in our country we don't have the drops for 1 alpha, so it's very difficult to manage it. We didn't normalize the phosphorus, but it was not our goal. But the alkaline phosphatase were normalized within 6 months. And the PTH stayed not within the normal range. She didn't have nephrocalcinosis after 6 months. We were not very good considering the growth velocity. So you can see that when we started the treatment, the growth velocity was good, and but she didn't normalize her high. But what was better were the X-ray, and you can see that in the hand, the wrist, it's not very well visible, but it was better, as well as the knees. So what wasn't good in our patient is that the growth velocity was not very good, just with the conventional treatment. And so we tried to search for another treatment, and we considered the treatment with growth hormone, and and we know that conventional treatment is not very good on height. Even it's better when the patient starts the treatment earlier. But in some cases, the final height is -2 standard deviation. And this is why in some studies they tried GH treatment, and in 2 studies, GH treatment improved the linear growth of the height, but this was not confirmed by meta-analysis of a review of the Cochrane database. So in our patient, we tried growth hormone treatment, but you can see that it was not really better with growth hormone treatment. So conventional therapy in XLH is better than nothing. It transiently increases the serum phosphorus level. However, it is associated with incomplete healing of rickets, residual skeletal deformity, and persistent short stature, and also gastrointestinal side effects, with the risk of metabolic and endocrine abnormalities such as hypercalciuria, nephrocalcinosis, and hyperparathyroidism. And this is why a new therapy had been tried. It's the burosumab. It's a fully human IgG1 monoclonal antibody directed at the FGF23. And what burosumab do is that it blocks the FGF23 signaling, and so it will increase the renal phosphate reabsorptions and the vitamin D levels. It will decrease the renal phosphate excretion, and so it will increase the serum phosphate level and improve the bone mineralization and decrease the risk of bone disease. So this is the first study where that was published with the burosumab, and the goal was to assess the efficacy and the safety of the burosumab in pediatric patients with XLH. And you can see that there was a significant decrease in the Thatcher Ricketts severity score in this in all the patients. All were treated with burosumab, but at a different a week, and you can see that by week 64, the abnormality were completely healed in this X-ray. This is another study comparing birozimab versus conventional therapy, and you can see that birozimab was better concerning the rickets total score, also the limb deformity, but what is very important is considering the height and the recumberant length and the growth velocity. So this is why if it's available, it's recommended to consider birozimab treatment in XLH children age 1 year or older, and in adolescents with growing skeleton if they have a radiographic evidence of overt bone disease and they are refractory to the conventional therapy, or if they experience complication related to conventional therapy, or if they are unable to adhere to a conventional therapy, presume that the adequate monitoring is feasible. So we don't have this treatment yet in Algeria, but here are the recommended doses. You will have it in the presentation that will be available. So I think I have just 3 minutes. I will go very quickly to the second case. Also young girl who presented with short stature, but what is very interesting in this patient, she had a hypoglycemic episode after 16 months, and she also had motor delay, normal intelligence but motor delay. She was very short. Oops. She had also hepatomegaly and signs of rickets, very severe rickets on the X-ray. And here are her investigations. So you can see that she had elevated alkaline ILP, but the difference with this patient and the other is that she had, as you can see, low pH, and she also had a fasting hypoglycemia and postprandial hypoglycemia, and she had proteinuria and glycosuria, making her being, I will go through it, having a Tony-Dobré-Fanconi syndrome. So this patient with a Tony-Dobré-Fanconi syndrome and hypophosphatemic rickets have what we call a Bickel-Fanconi syndrome. It's a type 11 glycogenosis that was confirmed, and this is a very rare disease. Oops, I think I can't go further. So I will stop maybe this. Oops. Sorry, I think they have stopped my presentation at 30 minutes. So just okay.
Thank you very much, Asmahani, for your presentation. We have a couple of questions in the chat, so I'm going to start with those.
Okay.
First, Dr. Sudan from India. I'm going to read them. Good evening, I'm a pediatrician. I am diagnosing many children with hypophosphatemic rickets in our country, India, since 2-3 years. Has it got anything to do with diet or post-COVID?
This is a very interesting question. Is it a real hypophosphatemic rickets or a nutritional rickets? I don't know. So she had maybe to be more specific about the hypophosphatemic rickets. We know that even in vitamin D deficient rickets, in the stage 2, they have low phosphorus level. So I don't know. I haven't seen more hypophosphatemic rickets after COVID. And if we talk about XLH, it's a genetic condition. So it isn't, it's not linked to COVID or everything else, but maybe it's a nutritional condition. Maybe those patients haven't received their vitamin D. Maybe they are, I don't know.
The same doctor is asking if you know if there's a research of rickets due to all nutritional imbalance, and it's something to be done as a preventive strategy in pregnancy.
Okay, so what we know is that vitamin D deficient mother, they can have children with vitamin D deficiency and with hypocalcemia at birth. So it's a cause of hypocalcemia at birth, be a cause of vitamin D deficient rickets. I don't know if I have understood her question, but this is my answer.
No, I think it's good. Another question. Could you go over why we should give alpha calcidiol in exchange of vitamin D in the management of XLH?
Yes, yes, of course. You can alpha calcidiol is more active, so it will permit to a better absorption of the phosphorus. But I have to say that we have some patients, because we don't have the drops, as I have said, we don't have the drops of alpha calcidium, and sometimes we give vitamin D2 or D3 drops, and it works not so well, but it's better than nothing.
Okay, and do you have any preference between alpha calcidiol and calcitriol?
Calcitriol. We only have alpha calcidiol, so I don't have the choice. Maybe you can answer.
I think both are excellent and they work best way to go. So another question is, what do you do for pain management associated with the disease, and it's usually necessary?
Yes, it's true. In older children, it may be the first manifestation, and what we just give first, we gave them paracetamol or another painkiller, but usually when you start the treatment with phosphorus and alpha calcidiol, it will be the first time they will have less pain. So it's really important to treat them just for this. But in the first weeks or the first even months, you can give painkillers. Usually in small children, even paracetamol will be efficient.
Perfect. Do you know if there's other drugs in the development pipeline that you know other than borosumab?
I don't know for another drug. Maybe Dr. Seilgens knows, but I know that borosumab work very well.
Yeah.
So, and we are waiting for it.
Yes. And another question. As initial lab vitamin D deficient rickets could mimic hypophosphatemic rickets, so to start with TRP before every case suspected?
No, we don't start with TRP. If we so the question is, what was vitamin D deficient rickets? Is this vitamin D
initial labs with vitamin D deficient rickets could mimic hypophosphatemic rickets labs because they both have hypophosphatemia.
Yeah, I will see your situation. If you don't have to, if the investigation are not very costly, you can do everything within the first investigation. But what we do in some cases, if vitamin D is low, we will give a dose of vitamin D, and we will see the child after 3 months, and we will assess the TRP at this time. But if the vitamin D level is correct, we will do the TRP immediately after.
Okay. Also, a question. Thank you, Muna Sharaf. In X-linked hypophosphatemic rickets, with this less interval between phosphorus supplement max phosphorus dose. So she's asking about interval and how and the max dose.
Yes, the more usually we give 4, or you can go to 6 times a day. So if it's 4 times a day, it's 6 hours. If it's 6 times, it's 4 hours. And the max dose, I think you shouldn't exceed 80 milligrams per kilo per day, because if it's more than this, it will be too high.
Exactly, and it will be for a patient. he will be in the bathroom all day long
Exactly.
with diarrhea because of the.
Yeah, but usually
of
we can manage it with. Usually we give. I don't give more than 60 milligram per kilo per day, and it's enough, and it's correct.
Perfect. This is just a question for me. Do you have tyrosinemia neonatal screening?
No.
Because at the beginning, you could be. I don't know if you could comment that.
Yes, unfortunately, we don't have. We for the moment we don't have any neonatal screening, and we will start only with the congenital hypothyroidism and phenylketonuria. But of course, in the all the renal tubulary disease, we have cystinosis, a lot of cystinosis, tyrosinemia, and also some cases of Bickel-von syndrome and other causes. So this is why my second line will be to do a glycosuria, and maybe we will do it actually. In first line investigation, we will do it's very easy to do a test for the urine spot, and just to do a strip test on the urine, and you will see if you have glucose or proteins, and the diagnosis is made. Yes.
Perfect. Thank you very much. I'm closing this session. So thank you everyone for joining us in this Meet the Expert session, and thank you, Dr. Lajus, for your excellent presentation.
Thank you very much. See you soon. Bye-bye.
See you soon.
The recording
Bye-bye.
has stopped.
Okay.
The session has now ended. Participants, please navigate to the sessions menu and go to the next session, plenary, on setting up a pediatric endocrinology and diabetes service in a resource-constrained setting, the Ghana experience. Thank you.
This meeting is being recorded.
University of Science and Technology in Kumasi in Ghana, where he serves as a consultant pediatrician at the Komfo Anuke Teaching Hospital in Kumasi. Dr. Emmanuel Ameayo's professional qualification include diploma in project design and management from Liverpool School of Tropical Medicine, as well as fellowship from Ghana College of Pediatric Physicians and Surgeons and the West African College of Physicians. His dedication to medical and research is evident through his numerous academic polls, including his previous position as a demonstrator and adjunct lecturer at the NUST University. He served as a local tutor at the Pediatric Endocrinology Training Center for Africa in Lagos in Nigeria. Dr. Emmanuel, the floor is yours. Please go ahead.
Setting up a pediatric endocrinology and diabetes service in a resource-constrained setting, the Ghana experience. I am Dr. Emmanuel Amiao, School of Medical Sciences, Kwame Nkrumah University of Science and Technology, Kumasi, Ghana. I have no conflict of interest. And the outline will be as follows: human resources, administrative support, multidisciplinary support, laboratory support, drug supply, challenges, and success story. Confanachi Teaching Hospital, this is how you see it if you are entering. With regard to human resource, certain pediatric endocrine clinic requires training in pediatric endocrinology. I trained at PEDCA, Nairobi, between June 2010 and December 2011. Training is important because it gives direction and empowerment. And in addition to that, there will be need for supporting staff, especially nurses. They also need training, but initially they can be trained on the job. In our clinic, we have 2 pediatric endocrinologists and 2 diabetes nurses. The pediatric endocrinologist, myself, and Dr. Sewa Bozu Asafoje. She was trained at Healthcare Lagos, Nigeria. Administrative support is very important because the hospital needs to recognize the trained doctor. They need to provide consulting room and consultation days. Our consultation days are Mondays and Thursdays. And the hospital administration need to assign nurses specifically to the clinic. Clientele, the patients are there. Even with the very rare diseases, they are there. Once you start the clinic, they will come. We started our pediatric endocrine clinic in January 2012 with no patient. As we talk, in 2024, we have a total of 1,250 endocrine patients. 300 of them are pediatric diabetes and adolescents. Multidisciplinary support. Multidisciplinary support is very important, and the pediatric endocrinologist, all the pediatric endocrinologists are the focal person. Psychologist is very important because a lot of psychological trauma is associated with endocrine disorders. Pediatric surgery is very important because they do the corrective surgeries. And we have a strong pediatric surgery team at Confanochi Teaching Hospital. The obstetric department is very important for prompt referral of babies with endocrine cases. And pediatric endocrine nurses are part and parcel of the clinic. Dietitians are important, and they deal with nutritional related problems associated with endocrine disorders. School administration is very important because we work with them to make life of children and adolescents with diabetes easy. And the family of these children with diabetes are very important for various reasons, because at times they even do not believe that endocrine disorders are medical disorders that require medical attention. Laboratory support is very important. However, laboratory support is very weak in Ghana. So simple point of care tests can be helpful. Many hospitals in Ghana do not have access to blood gas cells investigations. So we use urine ketones to diagnose and monitor DKA management. And we've been very successful with this. Some investigations are very expensive and they are even not available. Karyotype, for instance, we take samples and send them to South Africa or Europe or America for analysis, and it can take us up to 8 weeks or more before we get the report. Drug supply are very important in running pediatric endocrine clinics. The endocrine drugs are very expensive in Ghana because they have to be imported, and so it becomes a problem for them. It's not regular. There's a young adult with partial androgen insensitivity syndrome. You can see the fully developed breast, and you can see the penis, micro penis, because this child is at the age of this child when we saw was 20 years, and the testicular size, the testicular sizes are okay because they are 20 mils. He had surgery to remove all the breast tissues, and we have this drug, dihydrotestosterone gel. We don't have it in Ghana. We have this from Professor Jean-Pierre Shannon. I discussed this case with him, and he gave this. We've given to him, the patient, and we are following. There is some minimum improvement, but we are following to see what will be the final outcome. Education to the medical community is one of the things we do. We involve the medical community. We do workshop, continuous professional development for them. We also educate the general community. We go to schools and we go to marketplaces to educate the people. We also go to churches and we go to mosque. This improves knowledge, and as a result of this, some children have been referred even from the community and also from the various hospitals to our clinic. These are some of the pictures depicting the trainings we do. We form Ghana Society of Pediatric Endocrinology and Diabetes, GPED. Initially, I was alone when I came, and I realized doctors were making a lot of mistakes after they referred to me. So I decided to move around hospital to give sample education. This was good, but it was not effective. I saw that I was wearing myself off, and it was not effective. So I contacted the parents of the patients with endocrine disorders who had some education, lawyers, accountants, teachers, and they were happy. So we formed Ghana Society of Pediatric Endocrinology and Diabetes, GPED, with such parents. And we gave them positions, we gave them officers, and they were happy through this. And after that, Dr. Sewa Bulsha-Safwaje finished her training and joined, and Dr. Laila Aduchum also completed and joined us. So now the three of us are in Kumasi, and we do all these training together. GPED has done a lot of education. These are some, and the others that we've shown us. And as a result of that, management of type 1 diabetes has improved among doctors in Ghana, and also management of PK. These are some of the continuous professional development that we've done. We, however, have a lot of challenges. The first one was the nursing problem. Nurses are posted to our clinic. We train them, they become very good, but after some time, they take them to other clinics. This was disturbing. They bring, we train, they will take away, they bring, we train, they will take away. So it was disturbing. So we try to solve this by giving the nurses foreign training. I discussed and we trained one in Canada. Prof. Jean-Pierre Shannon helped and trained one for us. But she came and also left for greener pastures. She is in USC now. We also have a lot of myths. They believe that children with endocrine disorders are not, they don't have medical condition, but rather they have spiritual conditions due to cancers. And so they don't think that they should come to hospital. So this gives us a lot of problems. And most of them believe that children cannot have diabetes. They think it's only adults who should have diabetes. So for you to say a child has diabetes is ahead of. And so they think that if there is such a case, they rather should go for prayers or use herbal medication. Cost of treatment is a problem because the drugs supply are irregular. Some of the drugs are not there. We have national health insurance, but our health insurance does not cover many of the endocrine drugs. And cost of drugs are indexed to dollar because they have to be imported to the country. We also have problem of loss to follow-ups. We call our patients who do not come, but at times it's difficult because the parents don't even have transportation. Some of them live very far away. And another problem is that they have many other children who are healthy, so they don't see why they should spend the money they don't have on the one who is sick and they have to be with him in the hospital all the time. However, we have some success story. The clinic started in 2012 with no patient. As we talk now, we have more than 1,000 pediatric and adolescent and young adults with endocrine cases. 300 of them have diabetes, 275 of them have type 1. Another success story is that we now have structured supervised care for these children with endocrine diseases. We have also set up satellite clinics across Ghana, and we monitor them. And many doctors can now manage type 1 diabetes and DK correctly. There was a time that we had a workshop, and one after giving the teaching on presentation on DK, somebody walked to me and said, "Doctor, all our patients with DK, all our children and adults with DK die, 100% mortality. Now they manage DK with high degree of success." We've written guidelines for management of type 1 diabetes and DK. Our children with endocrine disorders, including diabetes, now survive to adulthood. Before we set up our clinic, this was not the case. Some have completed universities and looking for jobs. Few of them have started working. Some have learned vocation, others are learning vocation. Some have married and organizing their families. Now we are thinking of training pediatric diabetes nurses in Ghana. And if that is successful, maybe we'll scale it up to train doctors in diabetes and probably later on in pediatric endocrine disorders. For the training of the pediatric diabetes nurses, we are using the ADICA model that we are using in Tanzania. Thank you.
Thank you very much, Emmanuel, for the very, very fascinating talk. And thank you very much for presenting. So we'll give you the opportunity just to say something on the last session of the GPED, since you just joined in. You can go ahead, Emmanuel. Okay, ladies and gentlemen, Emmanuel has been struggling to join us because of the internet challenges in Ghana. So we lost him again. So, which means at this point in time, I would like to take the liberty to thank all of you who have made it to this plenary session and the information that we have collected. You can see how Emmanuel has started from the scratch in Ghana and how he has managed to build his clinic to over 1,000 participants. He has improved the quality of people with endocrine disorders, and he has improved the mortality as well. So this is really commendable, and this is what we are here for. We are here to make some differences in the people's lives. This is what really we are, more especially in resource limited setting, because the resources worldwide will always be limited. So it is incumbent upon us, call upon you to also follow suit, reach out to as many children with endocrine disorders as possible, improve the care of children with diabetes worldwide. So this is really quite a fascinating session. And in the chat box there, I can see many comments there in terms of the perspective. But since this is a plenary session, there's usually no questions, but check in the chat box. If you want to contact Emmanuel directly or contact me directly, you can get the contacts in the chat box. At this point in time, I am happy just to tell you that in Botswana, we have also set up the unit around the same time as Emmanuel has set up, and we have improved the quality of children living with the endocrine disorders, and the outcomes looks very good. So at this point in time, ladies and gentlemen, it is a great honor and privilege to close this session and bring it to an end. Thank you very much. May God bless you all and have a beautiful evening.
So we've come to the end of our wonderful meeting, and I want to thank you all for joining the first GPED annual meeting. We are so encouraged by the number of people interested in learning more and improving the care of children with endocrine disorders worldwide. We want to thank our wonderful speakers, our oral abstract presenters, our poster presenters. The work that all of you do is of such vital importance to moving care forward. Yesterday, we had the opportunity to hear from 6 oral abstract presenters and view over 30 posters. Overall, we had 46 abstracts submitted from 20 countries. I have the honor to present our awards in these categories. This was not an easy process, as there was a great diversity of topics from around the world. In choosing the winners, we looked at this with an eye to the utility of information provided within low and middle income countries and the potential impact to change or improve care. And with that, I will announce our oral presentation winner, which was our presentation on the evaluation and management of diabetic ketoacidosis in children and adolescents with type 1 diabetes at 2 hospitals in Mali, presented by Dr. Mokhtar Ba. And thank you, Dr. Ba, for your work to improve the care of children presenting with DKA. We hope that your work will develop into appropriate practice guidelines for pediatrics. Congratulations to you. Our poster presentation winner is a poster on the growth and neurodevelopmental outcomes of children with congenital hypothyroidism identified through DBS newborn screening at a tertiary care hospital in Pakistan
presented by Dr. Bushra Rehman from Pakistan as the lead author. And again, we want to thank you for your work and hope that your work will continue to emphasize the importance of newborn screening in improving outcomes and therefore the need for broader screening throughout the world. Congratulations to you as well. Before we completely close, I would like to point out that you will be receiving some information about how to give us some feedback about the program, and we do plan to use that to forward our plans for our next evaluation, for those evaluations for our next meeting. If it will be the completion of those evaluations that will trigger the receipt of letters of certificates of attendance for this meeting. So please do fill them out. They will be useful for you and also useful for us in a for planning for the future. We also encourage you all to join GPED if you are not already. Registration with GPED is free, and it will get you our various newsletters and other information as we move forward with projects. Yes, please join. There you have the QR code to join GPED. You can also find us on our website, which is globalpedendo.org. And please do join us if you have not already. Before we officially close, and please follow us on social media. We would also like to thank our supporters, our financial supporters,